together. Please.
Thank you very much, Professor Abdullah, for the invitation. Thank you, everyone, for being here. It's a pleasure to be among you. I mean, I feel a little odd to be interventionist in the heart failure meeting. Nonetheless, we always try to contribute. So the topic is I've been allocated to talk about is cardiogenic shock. Where do we stand in 2022? I'll outline what I'm going to talk. I have no conflict of interest for this particular talk. I'm going to talk about definition of cardiogenic shock, epidemiology, treatment of cardiogenic shock, and new advances in this treatment. By definition, this definition was, and it's still outstanding until now, from the shock trial. It's clinical and hemodynamic criteria. As you can see, systolic blood pressure should be less than 90 millimeter mercury for more than 30 minutes. There are supportive measures needed to maintain systolic blood pressure more than 90 millimeter mercury, end organ hypoperfusion, cool extremities, urine output less than 30 mils per hour, and heart rate more than 60 beats per minute. The hemodynamics, cardiac index less than 2.2 mil per minute per square meter, or wedge pressure more than 15 millimeter mercury. This definition tells us that those patients are really sick. When they hit the door, we need to look after them very carefully. Unfortunately, the incidence of cardiogenic shock remains quite high and it's growing. This data published in 2014, and there are new registry, I think it will be published soon, talking about the incidence of cardiogenic shock in ST elevation, myocardial infarction. And as you can see, the numbers exceeds nearly 2 million population. So it's a huge number, a huge burden of patients with significantly high risk. Even with age more than 65, they remains quite high and growing. This clinical entity remains lethal. It's very high mortality. We know a lot of those patients, they die despite every intervention we offer them. The mortality, in-hospital mortality during acute myocardial infarction, cardiogenic shock in over 23,000 patients remained over 50%. And even they discharge those patients, they remains at very high risk. You can see 60 days mortality data reach over 10% and will continue growing. This is as we know, this clinical entity remains very challenging. And this data, 2005, 2006, compared to 2011 to 2013, you can see what you can see here. This is from the cardiogenic with PCI only. Overall mortality remains high and increasing. Let me show you some data as what we can do for those patients to improve their outcome. This is the data from the US published in 2016 showing the majority of cardiogenic acute MI patients are treated in hospital community hospitals rather than academic government hospitals. The part of the pie is only 10%, although recently there are some more direction towards transferring those patients towards government academic centers to offer them the best treatment available. What are the treatment? What do we offer those patients in cardiogenic shock? So the patient hits the door, hits the ER with blood pressure 75. They look terrible, cold extremities. And what the first thing to do for those patients? As we all agree, we transfer them to the cath lab straight away. Now, revascularization, where's the evidence behind that? So we know in the European, this 2011, even 2021, the guidelines indicate it's a class 1A. So revascularization is key for those patients. The big question is, do we offer them hemodynamic support pre-PCI or after? That general, I don't think there is data to support at either approach at this stage. However, the sooner we apply perhaps the balloon pump or impeller in highly advanced, high volume centers, we improve those patients' outcome. And I'll show you some data about this. I just highlighted this in the European guidelines, say emergency bypass graft surgery, although I think the number of cases of those sick patients, they've been offered emergency bypass graft surgery are really rare. I don't think the numbers exceeds across probably the UAE, probably more than 10 or 15 patients. This is, we are all familiar with this. What shall we tackle on those patients? Those patients are quite often, they have multi-vessel disease. Shall we tackle all, or shall we tackle culprit lesion? We had a landmark trial, which was, as you know, published in 2016, showing that only culprit lesion. The reason why we still don't know that yet, and I think perhaps those patients, they stay the minimum period of time in the cath lab and in and out as soon as possible. Dealing with the culprit lesion, stick perhaps the balloon pump or impeller and send them back to ICU. This, talking about mechanical circulatory support, this is a really fascinating paper by Atkinson et al. In JACC 2016, talking about various, as you can see here, various hemodynamic support devices, and the two only that proven to be, well, not effective, much usable, is intra-aortic balloon pump and impeller. Now, but as we know, the impeller hemodynamic impact is much more prominent than intra-aortic balloon pump. Yet, is there any data to support impeller? Just in a show of hands, who in this room has used impeller? Yeah. So the intra-aortic balloon SHOCK 1 trial and SHOCK 2 trial, it was both of which were randomized controlled trial. The SHOCK 1 trial was small number, as you can see, 40 patients, and in the SHOCK 2 trial, there was nearly 600 patients. Was there any evidence that intra-aortic balloon pump insertion makes a difference for those patients? The truth is no, categorically no. Yet there is a lot of criticism for those two trials as the timing of inserting the balloon pump. There's a lot of discussion about this. Should we insert the balloon pump up front or in advance for those patients prior to doing the PCI? In those two trials, the balloon pump was used during the PCI or after the PCI. So quite often, some of the authors believe it might be late when we use the balloon pump, hence the negative outcome for this trial. And I think there is a shout for a new trial using intra-aortic balloon pump as soon as possible. They hit acute ER and certainly straight to the emergency department. In the UK, the registrar, our registrar, used to stick the balloon pump straight away in the patient before even we approach the coronary arteries. Impeller. It's a big name, and certainly it's very powerful hemodynamic support device. This is the FDA statement, and I'll read it for you because it's quite, FDA quite often, they are late in terms of approving any devices or any new technology. They're quite often 2 years or 3 years behind Europe. Most often the devices are tested in Europe, in China first, then in Europe, and then approved in the US. So the Impeller 2.5, CP5, and Impeller LD catheters in conjunction with the automated impeller controller console. Anyway, it's indicated for the treatment of ongoing cardiogenic shock that occurs immediately, which means less than 48 hours following acute myocardial infarction or open heart surgery as a result of isolated left ventricular failure. That is not responsive to optimal medical management and conventional treatment measures with or without intra-aortic balloon pump. The optimal medical treatment, the FDA defined it as include volume loading, use of pressors and inotropes with or without balloon pump. So your patient could be having intra-aortic balloon pump, yet you can use impeller device in those patients if they remain in cardiogenic shock. The data supporting the FDA indication, I mean, as you can see, it's not huge data. Certainly there's only one randomized trial, which is the IZAR shock trial. It only recruited 26 patients. As you can see, very small number of patients to conclude any evidence. Yet, I was surprised that the FDA really approved this trial, this indication. The overall, from a literature review, I think they used 2,981 patients, out of which nearly half of them or less had Impella. We know that trials in this clinical entity are very difficult to recruit patients. And as you can see, the number of trials have been discontinued due to the fact it was impossible to enroll patients, were quite a number of them. The French trial in 2006, and we all know our colleagues French, they are very good in recruiting patients, yet the trial was stopped prematurely because of low recruitment. The target was 200 patients. They only managed to recruit 19 patients over nearly a year period. The ISAR shock trial, as we said, it was completed. The IMPRESS trial, 2007, and it was a promising trial, yet again discontinued for the same reason. RECOVER 2, FDA-driven trial in 2009, also discontinued. And the DANSHOCK trial, they only managed to recruit 50 patients over 40 weeks. So recruiting patient randomized trial in this clinical entity is so difficult. It's proving day after day, hence the lack of evidence across the board over the last 2 decades, despite the fact the increasing number of cardiogenic shock, still lacking quite significant evidence. This is the mortality in acute MI shock, pre and post PVAD era. So this, if you can see here, no PVAD, 52%, whereas with PVAD era, dropped to 43% with significant p-value. Again, compared to ECMO, LVAD, PVAD was quite significantly better. I'm sure we're all familiar with the Impella device. I won't go through the technical side of it, but the outcome of this is the fundamentals of our myocardial perfusion. Increase oxygen supply and reduce oxygen demand. We reduce the mechanical work. We increase by reducing the wall tension, microvascular resistance, and coronary perfusion. We all know this is the key in terms of improving outcome in those patients. And Impella does all that by the book. IMPRESS trial was a trial using the Impella, published in JACC 2017. And as you can see, compared to balloon pump, there is no significant difference. So it is still, I think, early stages before we say we're gonna implant Impella in every patient with cardiogenic shock. Yet I think there are a big shout for more trials using the Impella device. And I think I've heard that so in the TCT, they may present some early data about this. We've defined this. This is survival to explant. This is what's the data, the distribution of Impella site outcomes. As you can see here, the higher volume, the better the outcome, survival in them. And as you can see, there's shift towards better outcome in different sites, 22% relative improvement in overall outcomes since March 2016. So I think the learning curve in terms of using Impella day in, day out has resulted in significant improvement. There are some centers now that can implant the Impella in very short period of time, and certainly that will make a big difference for those patients. We talk a lot about RV support devices, yet there is no evidence to support any of these devices to improve outcome in those cardiogenic shock. But I think there is more of, we should, as a cardiology community, pay more attention to the right ventricular support in those patients. I think we wait for the evidence to back up that theory. We need to standardize our approach. We should have a protocol, aerial initiation, hemodynamic support, and hemodynamic monitoring. I won't go through all this. I think Impella pre and post in IQ database and CVAD registry has shown significant improvements in terms of survival to device explant. As you can see in the CVAD registry, it showed from 41% to 65%. So there is scattered data, not a randomized trial, showing significant improvement using the Impella device. And there is, I think, general trend in those patients to start with the Impella and those. I would probably conclude here. Can I go back to the slide conclusion, please? The last slide. Yeah. So in conclusion, just I'll summarize, cardiogenic shock remains lethal. We know this. Early revasc improves survival. Mechanical circulatory support is redefining the treatment paradigm, and I think we need more trials in that regard. Protocol-driven approaches are promising. Thank you very much.
Excellent. Thank you very much, Albert.